menopause, HRT, and women. Today we have with us Dr. Stewart, and he's going to be talking about menopause and HRT. And I think it's going to be an amazing session. Wherever you're calling, wherever you're signing in from, wherever you are, you can come on and ask any questions you have. Just raise up your hand or put your questions in the question and answer section of this of the platform or in the chats, and we'll pick up those questions at the end of Dr. Stewart's talk, and he would answer those questions. So before we start, I want to say that everything discussed today does not replace the advice of your own renal doctor. So that's for kidney patients. If you notice anything, Stewart is an expert in this area, but usually we renal patients need to also speak to our doctors if we notice anything strange with with our bodies or anything that's we feel we are alarmed. We feel alarmed about. So I would advise you that anything at all, because you won't have access to stewards on a daily basis, speak to your renal doctors or speak to your transplant team. My name is Hilaria Sumu, and I'm a kidney transplant patient with 10 years experience in dialysis and just over 4 years as a transplant patient. I am the chair of WSH-BME Kidney Network. And on behalf of the Black Kidney Network and transplant patients everywhere in the world and their families who find it hard navigating government systems, we say welcome. We support with issues within the workplace, health inequalities, social services, education, housing. We also raise awareness about organ donation and kidney disease. And we have a monthly health webinar like what we're doing right now that educates the community about kidney disease and organ donation. So without further ado, I'm not going to waste your time. I just want to tell you a little bit about our charity. I will hand over to Dr. Stewart so he can get on this, because we don't want to waste any minute at all. It's going to be an amazing session. So if you have any questions, it's either you raise up your hand or you put your questions in the chat, and we would pick that question at the end of his talk and take it on from there. In any other issues you have, if you want to speak to Dr. Stewart afterwards, after this whole session, you can do that through our organization, WSH-BME Kidney Network, and all this information will be given to you at the end of the webinar. Thank you. Dr. Stewart, welcome, and thank you very much.
Thank you so much, Hilary. Good morning, good afternoon, good evening to wherever everybody is who's joined so far. Thank you so much for having me, Hilary. It's a real pleasure to be able to talk to yourself and everyone about women's health. So I'll start sharing my slides in a moment. So the first thing I want to ask is, can everybody hear me okay?
Yes,
yeah.
I can hear you.
Yeah, perfect, wonderful. So a little bit about me. So my name's Stuart. I'm a doctor working in Manchester and a final year GP registrar. So I'll be a fully qualified GP in the next few months. But I've been practicing as a doctor for 10 years and worked in hospital medicine and geriatrics for quite a while as well. But I've also done qualifications with the Faculty for Reproductive and Sexual Health, which is really where some of my interest in women's health began. But has also probably been influenced by the fact that I've got 4 sisters, a strong-minded mother at the same time. And actually, part of my life is spent, so half of my week is spent seeing patients, and then the other half of my week is spent doing research. And my research interests are around kidney disease, but also things that, in general, people may be overlooking. And kidney disease is definitely one of those areas where I don't think it gets the attention that it so deserves. And that really led me towards women's health as well. So in terms of today's presentation and what I'm going to talk about, it is just general information about menopause and hormone replacement therapy specifically. And the requirements for a patient who has had a kidney transplant are slightly different. So I would encourage you, if I've said something today which may not completely fit information you have been told by your kidney specialist team, there will probably be reasons for that, and that's just because of interactions potentially between some of the medications that we commonly use for symptoms of the menopause, and medications that you may be on if you have a kidney transplantation. Nevertheless, we do know that women that have had a kidney transplant, we do know that that does affect their menopause and can bring that forward or alter periods, for example. So even if there's something which I say today which isn't 100% tailored to your needs, I would use some of the information that I'm giving you today as a springboard into a further conversation with your specialist team. So without further ado, I'll start sharing my screen, and let me know if you can see this.
Yes, we can see it. Yes, we can see it.
Thank you, Hilary. So myself as a doctor, my interests from a clinical point of view, but also a research point of view, are really around health inequalities. And what I mean by that are the reasons why some patients have different health outcomes or experience different levels of health than other patients. And that's true for patients of different genders, different ages, different sex, different location geographically, whether that's in the UK or around the world, different levels of deprivation in society. I'm interested in the mechanisms which underpin why people have different health outcomes. But woven through there, I'm also interested in the way that technology can influence our health, specifically women's health, and a deep interest in kidney disease, because I think it's often overlooked. Underpinning all of this is also an interest in how we age and how we age in a healthy way. So I'm interested in not only our lifespan, but also our health span. We know they're two different things. So our lifespan being the amount of years that we live for, but our health span being the amount of years that we live in good health. So why am I talking to you today about menopause? And this was something which kind of dawned on me last year, that once you actually see menopause for what it is, and you move past the fact that it's a change in a woman's periods, because it's so much more than that, and you can see, and I'll convey that to you today, the far-reaching consequences that perimenopause and menopause has on a woman's health, well-being, whether that's or mental. Once you see it, it's very, very hard to unsee it. And I don't just mean that as a doctor, but I mean that also as just another person, another member of society. So let me show you this first graph, because this is a really, really stark graph, the message behind this. So what you can see here is essentially a bar chart of, along the x-axis, along the bottom, are the different ages of women. And up the left-hand side on the y-axis is then the rates of suicide per 1,000 of the population. And if we look at the tallest bar chart, it actually highlights that suicide in women peaks in the age of 50 to 54. And knowing a little bit about menopause, quite quickly, you can start to understand that something is going on here. Now, it's not fair to say that this is all menopause related, but we know that there is a correlation here between the stress that a woman goes through physically and mentally, and actually the decline in mental health that really starts to begin around the age of perimenopause and menopause. So as I said, once you see it, you can't unsee it. And what else do I mean by that? Well, if we look at the symptoms of the perimenopause and menopause, and don't get too hung up at the moment on the definitions between perimenopause and menopause, I'll come back onto that in a moment. You quickly see that lots of these symptoms, when a woman presents to her doctor and mentions some of these symptoms, there is a tendency and a temptation to sometimes explore each one of those individual symptoms as if it's one problem on its own. Now, looking at the list of symptoms, I'm sure lots of these symptoms resonate with women that may be on this webinar. So night sweats, hot flushes, mood swings, fatigue, nausea, joint pain, depression, irritability, palpitations, weight gain, anxiety, urinary tract infections, vaginal dryness, All of these symptoms we could technically explore individually, and that's sometimes what happens when women see their doctors. But actually, once you realize that going through the perimenopause and the menopause, when hormone levels start to fluctuate, lots of these symptoms are a response to changes in hormone levels, and the receptors, which are all around the body, then lead to lots of these symptoms. Now, I'm not the only person, obviously, who's interested in this area. I'm just one small cog in a machine, and a machine which is fortunately growing, that is trying to move the needle on women's health. Now, in the UK, we're really kind of, I think, at almost a watershed moment where we're seeing so many different groups, not just doctors, not just public health practitioners, literally people throughout all of society coming together to actually recognise the impact that menopause has on women. And we have an incredible MP in the Labour Party, Carolyn Harris, who has fought long and hard to actually get this recognition within Parliament. And last year a bill was passed which actually highlighted the need for a task force to look at the impact of menopause in all of our institutions and examine the impact that it has on women throughout society. And Carolyn Harris said that menopause support in this country is falling short and failing women. GP training in medical schools, support in workplaces, public health messaging and curriculum content in our schools all need addressing. And I couldn't agree more, because I've been through that medical system and I know what kind of education that I've received to date on menopause care. And I know it wasn't enough, but have been fortunate that actually new courses have now started to appear, which now educate healthcare professionals on the importance of menopause. So why am I having to talk to you about this today? Because actually menopause affects 50% of the population, and it affects all women. So you could say, why is it, given all of the latest advances that we've seen over the past 20, 30, 40 years in modern medicine, why is it that I'm having to do a talk now on actually something which is quite simple? It's a physiological change in a woman's life, which is associated with symptoms and future health risks that we've actually known about for many, many years. Well, I think it's because of this study, which was published in 2002. So the Women's Health Initiative randomized control trial, one of the largest randomized control trials in the world, which was then looking at the risks and the benefits of estrogen and progesterone treatment for the symptoms of the menopause in postmenopausal women. It was one of the largest studies that's ever been done across multiple countries. And unfortunately, the way that that study was conducted and the way that that evidence was written up and shared with the media was done in an extremely damaging way. In actual fact, the investigators who were the principal investigators of this study have now come forward to try to highlight that actually the way that this information was shared with the public was done in a way that actually contravened standard academic practices. And this was a study which was actually, the headline findings were released the next day in the press, almost as soon as the paper was published in the JAMA journal. So what happened after 2002 was what I like to call the winter of women's health. And actually over the past 20 years, we've been living through this winter where there has been far less research into women's health, menopause care, and hormone replacement therapy. And ultimately, that study was an example of bad science in many, many ways. So what I want to do today is actually highlight to you two overarching intentions that I have. I see my job as a doctor and a researcher to simplify complexity and to share that complexity in simple form with you so you can understand your body, your health, and your treatment options. My second intention is actually to support you in speaking to your own healthcare professional with evidence-based information to help you make the decisions that you need to improve your own health. So let's start. What is the menopause? Now, I like to start with the menopause and then work backwards because it makes a little bit more sense. So the menopause is a time when it's really a time point that we look back and say to a woman, have your periods stopped over the past 12 months, or have you had a period in the last 12 months? And if a woman hasn't, then we can quite often confidently diagnose the menopause. And then technically from that point, once we have diagnosed the menopause and said that you are now menopausal, technically the correct term is postmenopausal, because you are now after that time point when periods have stopped. But what does it mean that periods have actually stopped? Well, actually, it means it kind of marks that the end of a woman's reproductive years, and that actually the ovaries, which produce sex hormones in a woman, so estrogen, progesterone, and testosterone, at the point of the menopause, that though the creation and dispersion of those hormones throughout the body have reached actually quite a significantly low level, that can no longer actually release follicles and ovaries in order for a woman to get pregnant. Now, when we talk about the perimenopause, all that peri means is near or round about. So really the perimenopause is the time before the menopause when estrogen levels start to decline. And it may be associated with changes in periods, which are often a common symptom, and a variety of other symptoms. So then if we think about the premenopause, which is actually just when a woman may be having regular or irregular periods, but no symptoms of the menopause. Now, some women may have heard of early menopause, and early menopause specifically relates to symptoms of the menopause or going through the menopause between certain ages. So if your periods have stopped for 12 months and you're over the age of 45, we would call that menopause. And the average age in the UK is 51 years. Now, an early menopause is if that happens between the age of 40 to 45. But if it's less than 40, which is a very early menopause, we call that premature ovarian insufficiency. And this is important because actually for the top two layers here, so menopause or early, when we discuss the treatment options with hormone replacement therapy, we naturally discuss the risks and benefits. However, the guidelines for hormone replacement therapy for premature ovarian insufficiency are slightly different, in that the guidelines strongly recommend hormone replacement therapy as a treatment which should be initiated quickly because of the long-term implications of not doing so. So why is this important to understand what menopause is, and why are we looking at this in a completely different light now? Well, if we look at the time between a woman is born to the point she is menopausal, that roughly accounts for the majority of women, about 2/3 of their life. So actually you spend a third of your life, a really significant chunk of your life, in the menopausal phase. And actually that's very, very important, because it's not just an afterthought, it's not just a few years. And during that time, several other diseases, conditions actually increase in prevalence. So understanding actually what women go through once periods have stopped, once they're in the postmenopausal period, is really, really important, because it creates an opportunity for us to influence or mitigate the risk of some of those future diseases. So symptoms. We know that about 80% of women report menopausal symptoms or perimenopausal symptoms. And perimenopausal and menopausal, the symptoms are just the same. It's just depending on the time point in which we say it's perimenopausal or menopausal. We know that about 25 to 40% of women report severe or moderate to severe symptoms of perimenopause and menopause. So we know that actually it has a huge impact on women. And this isn't just a couple of symptoms like hot flushes, mood swings, night sweats. These are symptoms which correlate with the fact that estrogen and the receptors in which estrogen impact throughout all of the body sense the fluctuating levels of hormones. And for example, when a woman has a hot flush, what the body is responding to there is actually estrogen levels being very low. And that's why sometimes actually women can really struggle overnight with interruptions in sleep because of hot sweats, because actually that low estrogen level can stimulate quite a significant response from the adrenaline system in the body. And obviously adrenaline at night can wake you up. So what impact does this have on women? So a study with the British Menopause Society actually highlighted that 45% of women felt their menopause negatively impacted their ability to work. If we look at the impact on mental health, the graphic that I showed you earlier really highlights that picture of the impact on mental health at that age between 50 to 54 at its peak. But I want to show you this one as well, because I think this is actually overlooked. Even though I think societally we know this and we experience this, but this graphic is actually showing you the number of divorces by age between men and women. And you can actually see there that the peak for women is at its highest in the 45 to 49 age range, and is still high in the 50 to 54 age range. There is obviously a slightly shorter peak in 35 to 39, but one of the most important things here is that menopause is not just about periods stopping. Menopause is about significant changes in a woman's physiology, which has an impact on her physical and mental health. And that is clearly evidenced by lots of studies that we know have been done on the likes of divorce rates, suicide rates, impact on work. One of the conversations that I often have with women that I see in clinic is quite often there can be a focus on the acute symptoms that a woman is experiencing during the perimenopause and menopause. But actually there's another part of this story which I don't think gets the attention that it deserves. And as a researcher and as a GP, this is something which is very, very close to my heart, because in general practice, we spend a lot of time trying to reduce the risk of bad things happening in the future and improving health. So we know that actually the menopause is associated with several future health risks. So I want you to have a look at this kind of timeline from menopause, unfortunately, to death. I know it sounds a little bit morbid, but we know that several diseases start to increase in prevalence after menopause or in the postmenopausal period. So type 2 diabetes, we know, starts to increase. We know that women who are premenopausal suffered far fewer infections from COVID, and that's because of the protective effect of estrogen immune system and the way that it modulates the immune system. We know that depression starts to increase after menopause, obesity, arthritis, osteoporosis, heart and kidney disease, incredibly, incredibly important. We know that actually women who've had hormone replacement therapy have lower rates of kidney disease, and there is clear evidence which shows that hormone replacement therapy has a kidney, a protective effect on the kidneys. And we know that after menopause, the rates of dementia naturally increase. So how do I diagnose menopause? So when I'm in clinic, I use a validated questionnaire, so a menopause symptom questionnaire. And this is taken from an incredible resource that we have in the UK, run by it's by a company called Balance Menopause, which was founded by a GP and menopause expert in the UK, Dr. Louise Newson, who is an advisor to the NHS menopause programme, but also runs one of the largest menopause clinics in Europe. And this menopause symptom questionnaire is just slightly modified compared to, it's based on something called the Green Climacteric Scale, which is an internationally validated menopause symptom questionnaire. So when I'm seeing a woman, I always use this symptom questionnaire because it gives me a really good baseline understanding of the symptoms she's experiencing, but also those symptoms also correlate with potentially estrogen deficiency, progesterone deficiency, or mismatches between those two, and also testosterone deficiency. Now, I know I've just said testosterone, and I will come back onto that because testosterone is for women also. So when I see a woman, I complete the menopause symptom questionnaire, and that gives me a really good understanding of whether the symptoms she's experiencing could be menopause related, but also in understanding whether I should do some other further investigations. Obviously, I base my decision making on a full history and an examination, and sometimes blood tests. Now, typically for women, we don't need to do blood tests if they have a typical menopause symptoms. They're over the age of 45. We don't usually have to do blood tests to confirm that diagnosis. However, with certain symptoms, we may then think, well, actually, could your symptoms be due to something else? For example, like thyroid disease. We may want to do at that point a set of baseline investigations to help us rule out any other causes. Now, when I speak to patients, I also highlight the use of this app, the Balanced Menopause app. So the Balanced Menopause app is essentially a whole host of resources for women, but it includes the Balanced Menopause Symptom Questionnaire, which really diagnostic capability in the hands of women. So actually, I say to women, once I've spoken to them and maybe have diagnosed menopause, I want you to use the app now to start to track your symptoms and to see how those symptoms change over time as we start to make changes to see if we can improve those, whether they are HRT based, lifestyle based, or other treatments potentially. So just as a reminder, NICE, the organisation which assimilate evidence for clinicians in the UK to bring in essentially the best evidence that we have to inform clinical decision making. The Menopause Clinical Knowledge Summary from 2021 highlights: do not routinely use blood tests to diagnose perimenopause or menopause in women aged over 45 years in otherwise healthy women with typical symptoms. Sometimes we will use them in certain cases, but as a rule of thumb, quite often the story, the symptoms really gives the points towards the diagnosis. So what treatment options do we have? So broadly speaking, we have three different treatment options. We have lifestyle interventions, non-hormone replacement therapy, and hormone replacement therapy. So lifestyle changes, naturally I recommend these to every woman, just because actually some women don't know about some of these things, and built into these lifestyle changes are actually just habits which can improve overall health. However, I often find that just lifestyle changes on their own aren't enough to actually treat many of the symptoms of perimenopause and menopause. And naturally, those lifestyle changes don't allow you to influence to as much a degree potentially those future disease risks. When it comes on to non-hormone replacement therapy, we have some options like antidepressants, which are not used for their antidepressant capability necessarily, although if a woman has experienced changes in her mood, there may be benefits. However, we do sometimes use these for hot flushes. Nevertheless, we know that actually estrogen replacement therapy or hormone replacement therapy in general is the best treatment for hot flushes and many symptoms of perimenopause and menopause. So we have that middle treatment option if needed, which also includes some other drugs that we can use, potentially cognitive behavioral therapy, vaginal estrogen, which isn't actually, it's not classed as HRT, even though it's medicated vaginal cream because the dose of the estrogen in that is so low, and then also vaginal lubricants. However, I'm going to focus on hormone replacement therapy because we know of the benefits of hormone replacement therapy being extremely useful for the acute symptoms of perimenopause and menopause, but also for reducing the risk of future health conditions. So, your sex hormones. You have a lot of estrogen and progesterone, and I have many conversations with women where these are the two hormones that they have, and hormone replacement therapy does cover both of these hormones, but it also can cover testosterone as well. And what a lot of people don't realize is that actually women have 3 times as much testosterone as they do estrogen. And that's because testosterone is an incredibly important hormone for bone health, for keeping the strength and size of muscles, which are incredibly important, for brain health, for heart health, for libido, for being able to think, for cognition. So when we're thinking about hormone replacement therapy, one of those take-home messages that I'll share later on is actually that testosterone is everybody's hormone, and it's not just for men, it's not just a male hormone. So what does HRT actually look like? Well, on the left, we have the estrogen options, and really the vast majority of my patients, I prescribe transdermal estrogen, which is estrogen via the skin. And here we have a combination of two gels, so estrogen gel and Sandrina gel, and also Everel, an estrogen patch. Now, I have no commercial affiliation with any of these companies, but these are three that I regularly try to use because I'm familiar with using these and have experience with these, and the sometimes the small side effects that we can get. For example, with using a patch, you can get some local irritation. Sometimes, not everybody gets that, but some women do. And then we have other patches which sometimes we'll swap onto if a woman has a small reaction to the adhesive in the Everel patch. In the middle, we have the progesterone component of hormone replacement therapy. And the important thing to note here is that women who have had a hysterectomy, so the womb has been removed, do not need progesterone. The reason that we're giving progesterone is actually because the way that I describe it is that estrogen is the workhorse of hormone replacement therapy. The impact of estrogen on the womb is that estrogen causes the lining of the womb to thicken. And obviously, women will know this as they have a normal cycle and then a period. That if an egg is not fertilized and implants into the lining of the womb, there are then changes in their hormones, and a woman will have a period. What the progesterone allows us to do is actually keep the lining of the womb thin and prevent excessive accumulation of the endometrium and then causing bleeding, essentially. If you have a womb and you were to take estrogen on its own, there's an increased risk of endometrial cancer. But giving progesterone neutralizes that risk or significantly reduces that risk. So say women with a womb, we would always give combined hormone replacement therapy. And that's a combination of estrogen and progesterone. Now you'll see on the right-hand side, I've also included testosterone on there. And often after I have assessed a woman's need for hormone replacement therapy, if it's indicated and she wants to go ahead with that, then once we have started estrogen and progesterone and got to a position where we think, you know what, the estrogen and the progesterone, we've got those doses right, we've covered the majority of those symptoms, or at least those symptoms which are related to estrogen levels being low, I'll then think about, actually, do we need to add in testosterone? Now, in the UK, testosterone replacement is licensed for women with low libido. But we know from other research that testosterone replacement has several other positive effects as well. So usually after being on estrogen and progesterone for a few months, I'll then start to think about, actually, do we need to introduce testosterone? If a woman doesn't have a womb, then she would just be on estrogen replacement and wouldn't need the progesterone. So when I'm speaking to a woman about the benefits and the risks of hormone replacement therapy, I find this tool where the link is pasted just in the bottom there by Wellspring Health, which is a risk calculator which displays benefits and risks in a visual way to help decision making. It was designed by a team at, I think, Imperial College London or UCL. I'll double check that for you. But it takes several pieces of high quality evidence and pulls all of those into one calculator and allows us to start to explain to a woman and actually show what the benefits and risks of hormone replacement therapy look like. So I'll show you now, for example, when I go into the tool, I select the age of a woman, whether I'm thinking about combined hormone replacement therapy or just estrogen-only hormone replacement therapy, and whether her periods were more than 12 months ago or whether she's had periods in the last 12 months, because that dictates also the type of regime that I'm going to go for. So the graphic that it starts to come up with. If I was then prescribing hormone replacement therapy, so combined hormone replacement therapy for these women, this highlights that 96% of women would have an improvement in mood since starting hormone replacement therapy. In terms of when that actually happens, that's variable and when that's experienced. But I often find that actually within a few months, women start to report improvements in their mood. And actually once hot flushes and improvements in sleep happen, some women report that much sooner as well. Now, vaginal symptoms are very, very common and not talked about very often. So vaginal dryness is a very, very common problem. It's estimated about 70% of women going through the menopause experience vaginal symptoms, but actually only about 7 to 10% of women have the confidence and the courage to be able to raise that with a healthcare professional. But we know it's very, very important because actually it affects intimacy with partners. The symptoms can increase the pain with intercourse, but also the frequency of urinary tract infections. And commonly we see women presenting with what sounds like a urinary tract infection, and we do multiple urine samples that don't grow any particular bug. And actually that is a real cue for doctors and for patients to say, actually, maybe it's not infection related, maybe it's because of the vaginal dryness that I'm experiencing. So hormone replacement therapy is very, very effective for these symptoms, but vaginal estrogen is also incredibly effective as well. And we use those in combination. We know during the menopause and when estrogen levels are at their all-time low, that can massively impact on sleep quality. And actually hormone replacement therapy, 56% of women who experience hot flushes report improvements in their sleep when starting hormone replacement therapy. We know that hormone replacement therapy is associated with a lower risk of cardiovascular disease, so whether that's disease affecting the blood vessels, the heart, the kidneys, and the blood vessels in the brain. And actually evidence shows that there is a 52% reduction of the risk of heart attack, heart failure, or even death due to heart disease. So huge, huge numbers. And that really ties in with the evidence that we have for essentially the diseases which are the top killers of women. It sounds very morbid to discuss it in that way, but we know that actually most women die from dementia and cardiovascular disease as opposed to breast cancer. And we'll come on to breast cancer in a moment because that is one of the top reasons not to go on hormone replacement therapy, whereas actually the impact and the improvements they can experience because of HRT massively reduce the risk of future diseases which stand to have a bigger impact on their lives as opposed to breast cancer. Now this slide's an interesting one because there is another truth behind this slide. So we know that women who are on hormone replacement therapy have a 22% reduction in the risk of a fragility fracture if they have osteoporosis. So osteoporosis is thinning of the bones, and that can happen in parts of the spine, the legs, and all parts of the body really. But some of the most critical areas are the hips and the lower parts of the spine and the thoracic spine also. The risk there is that with thin bones, if there are fractures, what happens after the fracture is really significant. So a lot of people don't realise, but actually, if we looked at all the people over the age of 60 who have a hip fracture because of osteoporosis, in 12 months' time, a third of those people will have died. And that is a headline which doesn't get enough attention because actually a hip fracture with underlying osteoporosis has a major impact on people's lives. So we know that hormone replacement therapy reduces the risk of a fracture, but we know that it has an even bigger reduction on the risk of even developing osteoporosis. Because hormone replacement therapy is actually the best treatment that we have for thinning of the bones, better than the treatments like bisphosphonates, for example, which are commonly prescribed medications for osteoporosis. Now, I recently published an article in a medical journal called the Lancet Regional Health Europe, with several other experts in this field on infection and menopause. And actually, what we know is that estrogen has a huge protective effect on the immune system by modulating parts of the immune system. And actually, we know that patients who are premenopausal, so who have stable and normal estrogen levels, they have far lower rates of COVID infection. But interestingly, what we also know is that some of the symptoms of long COVID overlap very much with the symptoms of perimenopause. So we are urging patients that may think they have long COVID, for example, to actually download the Balanced Menopause app and just fill in a menopause symptom questionnaire. Because actually, we do know that some women who have had long COVID have had a trial of treatment with hormone replacement therapy, and actually we think some of their symptoms were more related to perimenopause and menopause as opposed to long COVID. So what are the risks of hormone replacement therapy? We know that the risks which were communicated in 2002 were the initial findings were erroneous in several different reports in parts of that study, and the group who originally released that report reanalyzed and then reanalyzed their data several times afterwards, and then changed some of the wording that they had used about some of the risks of hormone replacement therapy. So over the past 20 years, there's been a really fierce kind of dialogue in the scientific community about what the true risks of hormone replacement therapy are. I've got to say that this field is evolving. There is more research going on, and international groups are re-looking at the existing evidence and also looking at new studies to say, can we be certain, or can we improve upon what has happened over the past 20 years to have more confidence in prescribing hormone replacement therapy? So what we do know are that with older forms of hormone replacement therapy, like tablet-based estrogen, that was associated with an increase in blood clots in the arms, the legs, the lungs, and also stroke. However, the type of estrogen that we commonly use now, so the estrogen that goes via the patch on the skin, or the gel that you rub into the skin, or the spray that you spray on the skin, the transdermal estrogen has no increased risk of blood clots or stroke. And that's a really, really important point, because that was probably the second biggest reason why people were scared of using hormone replacement therapy. Now on to breast cancer. So the best evidence that we have at the moment is still that the more that you use hormone replacement therapy, and if you use it for longer periods, over 5 years, for example, that there is a slightly increased risk of breast cancer. But that is also dependent on whether you are using combined HRT, so estrogen and progesterone, or just estrogen only HRT. And what I mean by that is actually that women who have had a hysterectomy and are only on estrogen hormone replacement therapy have no increased risk, or some evidence actually shows a lower risk of breast cancer than the general population. And I'll show an infographic in a moment which communicates this topic about risk in quite a nice visual way. Ovarian cancer, there is no increased risk with estrogen only HRT, and a very, very slightly increased risk with combined HRT. Again, different groups look at this differently and say, well, actually, because it is the tiniest increase of risk of ovarian cancer with combined HRT, that actually clinically it's not very significant, and there are other factors at play which could be potentially increasing that risk. So when I talk to women about breast cancer, I often use this infographic to help me communicate that, because actually what this highlights, this tool from the British Menopause Society and the Women's Health Concern Charity, is that when healthcare professionals communicate risk to patients, they often leave them quite confused, because what does risk actually mean? So what I do is I go through this line by line and say, okay, if we had 1,000 women in front of us from a UK population, and they were aged between 50 to 59, and we were looking at all of those 1,000 women over the next 5 years, if none of them were on HRT, 23 of those women would be diagnosed with breast cancer. And they were going to be diagnosed with breast cancer anyway, because breast cancer is actually common and it increases with age. And there are many other factors which increase a person's risk of breast cancer. So taking HRT out of the equation, 23 of those women would develop breast cancer and be diagnosed with breast cancer. So if we put those women on hormone replacement therapy, so combined hormone replacement therapy, there would be an extra 4 women who would develop breast cancer. But as I said before, that if you are only on estrogen hormone replacement therapy, there is a potential reduction in the risk of breast cancer. So if we had all of those women on estrogen only HRT, instead of there being 23 cases of breast cancer, that would actually drop to 19 cases of breast cancer. Now, I'll skip through some of the middle ones, because I think really what I'm trying to highlight is that multiple risk factors are present in every patient, and some of this has been blown out of proportion, and there is an overemphasis on the risk with hormone replacement therapy. For example, the second line to the bottom actually highlights that if all of those 1,000 women were overweight or obese, there would be, in addition to the existing 23 cases of breast cancer, because of being overweight or obese, increase the number by an additional 24 cases of breast cancer. Really, that highlights that actually things, that the risk factors that we currently live with, like smoking, like alcohol, like the amount of calories that we consume, are much bigger risk factors for breast cancer than hormone replacement therapy has been. But because of the way that the evidence has been communicated historically, there has been an overemphasis on the risk with hormone replacement therapy. If we actually look at the impact that exercise for 2.5 hours per week has on breast cancer risk, we find that actually there would be 7 fewer cases in that 1,000 of breast cancer, just because of the impact that exercise has on your cancer risk. So I know that's quite complex, and I'm happy to take questions about that one, because even using this graphic, I still find it's sometimes quite difficult to get your head around. Now, moving on to my second intention, which was helping you make decisions so you can have an evidence-based conversation with your own healthcare professional. I always say, the simplest thing you can do is download the Balance Menopause app, or just complete a menopause symptom questionnaire, which you can easily download online if you just Google menopause symptom questionnaire. The benefit of the app, for example, is that it is free. It comes in many different languages. It's been downloaded over 250,000 times across the world. There are loads of free resources in there which help you understand the basics around perimenopause, menopause, your symptoms and your health risk. But it also puts the power in your hands of actually making this diagnosis, because we know that lots of women going through the perimenopause and menopause actually know that it's hormone related, because they have experienced similar symptoms all of their life as they have had periods and gone through their cycle and had contraception before and been pregnant. So the Balance Menopause app really supports actually women and their own internal knowledge of their bodies to be able to make this diagnosis. One of the things which I am often asked in clinic is about how long a woman can take hormone replacement therapy for. And the British Menopause Society updated their guidelines last year to actually say that arbitrary limits should not be placed on the duration of usage of hormone replacement therapy. If symptoms persist, the benefits of hormone therapy usually outweigh the risks. So I wanted to share that with you because actually I have lots of women who have been on HRT for 10 years and have so much anxiety about coming off HRT and have tried to come off HRT and have found it incredibly, incredibly difficult. And actually being on a dose that helps with their symptoms and keeps those symptoms at bay and just getting that dose right is actually the most important thing. And then just making sure that we're aware to have regular checkups, breast awareness, know how to examine your own breast. Be mindful that any bleeding that happens after periods have stopped, so vaginal bleeding should be discussed with your healthcare professional. And any changes in your overall health while you're on hormone replacement therapy, just discuss it. All of those things are not necessarily reasons to absolutely stop HRT. It's an opportunity to simply discuss the hormone replacement therapy that you're taking and what are the best next steps. This is something which I often share with doctors as well, because lots of my colleagues actually aren't aware of this, but estrogen only HRT is associated with little or no increase in the risk of breast cancer. And actually many groups and studies have actually shown a reduction in breast cancer risk. In actual fact, in the 1950s and 60s, one of the first treatments for breast cancer was estrogen treatment. So it's not as simple as estrogen's the bad guy and causes breast cancer, and we know that from lots of evidence. So this is reflected in this statistic, and I think that's a really important takeaway message, because I'm sure many of you will know women who've had a hysterectomy and may still be unsure about estrogen and hormone replacement therapy. So finally, my take-home messages are that menopause is not something to be feared. It is in fact a major opportunity to influence your current and your future physical and mental health. It's more than just your symptoms. It's a point where a woman's risk of future health problems begins to rise. And actually seeing menopause as an opportunity to intervene can actually be, I call it almost an insurance policy, that making the right decisions during this time and finding treatments which are able to reduce that future risk can be an insurance policy for the future. Hormone replacement therapy is a safe and effective treatment for symptoms of perimenopause and menopause, where the benefits usually outweigh the risks. And HRT is also a safe and effective option for reducing the risk of many future health problems. Testosterone is for women too, and women should always receive personalised treatment plans that cater to their specific needs. And that's really reflected in the NICE menopause guidelines as well. So that's the end of the presentation. Thank you for staying with me all of this time. I'm just going to stop sharing the presentation and I'm happy to take questions.
Okay, thank you very much, Stuart. That was an amazing session. I've actually learned a lot today. The questions are coming in. I'm just going to, start with the one I'm just looking at. Ayesha says, which hormone drops when we are in menopause?
So both of them start, well, all three of them start to change. So women are often most familiar with estrogen and progesterone. And actually some of the symptoms are because of the change in the ratio to estrogen and progesterone. But the way that I often draw this, and I draw lots of diagrams with my patients, is that when you are in the premenopausal period, your hormones go through this cycle, depending on what your cycle length is. And then when you're in the perimenopause, they start to change more like this. And the variation between the high point and the low point starts to change. And sometimes your levels can go higher than they were before because there are feedback loops. Because when the body detects a very low level, the brain detects that and then tries to make the the body secrete more of the hormone. And sometimes you can then overshoot and produce more estrogen, and then the body turns off almost some of that production, and then it drops again. So the important thing is that during the perimenopause, all the levels are changing. We know that with testosterone as well. But then when the periods have stopped for 12 months, that really indicates actually a new, much lower level of estrogen, progesterone, and testosterone. I think I lost you there, Hilary.
Okay, I took myself off so that they would stop looking at me and concentrate on you. So our next question is, does vaginal estrogen have any effect on systemic symptoms of menopause? Now, that is a wonderful question.
So vaginal estrogen dose is very, very low. And for example, if we think about the Mirena coil, which has progesterone in it, we know that that acts locally, and sometimes we choose a Mirena coil, which has progesterone in it, for patients that either want that form of contraception, or because the progesterone pill, for example, was having too many systemic effects on the body. So usually vaginal hormones act locally. There may be some systemic absorption, but far, far less than taking the doses that we would give either via the gels, the patches, the sprays, or the tablets.
Okay. Our next question is from Chikodi, and she's asking if HRT is ordinarily available under the NHS.
Yes, absolutely.
Okay, and the next one is a long one. I'll just put that on screen, and that's from E. Roberts. So she says she's 61 years and post-menopausal, but not on HRT. She has CKD, which puts her at higher risk of heart disease. So could she benefit from starting HRT for its protective effect on both the kidneys and the heart, or is it too late?
So it's a good question, and this is an area of my interest which is developing because I do research into chronic kidney disease. The first thing I would say is that I'm not an expert in chronic kidney disease from a clinical point of view. That would be a kidney specialist, but I do work closely with the kidney specialist team. And my understanding so far is that with established kidney disease, but where patients where they haven't had a transplant, we still have windows of opportunity potentially to try hormone replacement therapy. Even post-transplant, there are patients that try hormone replacement therapy, but there are other factors that we need to think about, which I'll come on to in a moment. So I don't think it's too late, and we know that chronic kidney disease is one of the biggest risk factors for heart disease. Yeah. In actual fact, patients with chronic kidney disease, more patients will experience another form of cardiovascular disease than actually progressing to end-stage kidney disease in itself. Mm-hmm. So we know that the cardiovascular risk with kidney disease is really significant. So actually going on hormone replacement therapy, when we know it's effective at slowing down the progression of kidney disease or different types of kidney disease, is an opportunity. What I would say, though, is that chronic kidney disease is an umbrella term, and there are lots of different causes of chronic kidney disease. So it really also depends on the type of kidney disease that you have, and I think that's the opportunity at which I would say, if I was speaking to you as your GP, I would say, I think we need to have this conversation between myself, yourself, and the kidney specialist to say, what type of kidney disease did you have? I know that you put IgA nephropathy in that description there. So I caught that. But I think that's an opportunity then to discuss that between the primary care doctor, myself, who probably has a lot more experience of managing menopause than a kidney specialist would, and speaking to the kidney specialist to say, okay, what evidence do we have for hormone replacement therapy in stage 3 kidney disease, stage 4 kidney disease, stage 5 kidney disease, and finding out what the kidney team would want to do, because equally every type of kidney disease is different.
Okay, so in terms of kidney patients, now we most of the time we are on well, everybody is on anti-rejection medication. So with this HRT, how safe is it? What are the contraindications if we take HRT alongside our transplant medication? Is there any danger? Is it harmful?
So this is a really, really good question. So I've been looking at the evidence for this because I've had a patient who's also asked me about this. From my understanding, we don't have a robust national guideline for hormone replacement therapy for patients that have kidney transplant.
Okay.
And that is because of the complexity of actually adding in additional hormones and the effect that that can have on the immune system. So we do know that anti-rejection medication is trying to dampen down the immune response so you don't reject the transplanted kidney. And that is the most important thing, okay?
Yeah.
We do know some patients, so there is some evidence from some cohort studies where they followed 600 women that had hormone replacement therapy and that was really struggling with some of those symptoms that I described earlier. So the changes in mood, hot sweats, depression, joint pains, muscle aches. Yeah. And they found that hormone replacement therapy in those patients was effective in the majority of women with those symptoms. Okay. A group of those patients then started to have some side effects because of the estrogen, they think. Okay. And they think what was happening was that the estrogen, because it has a positive impact on the immune system, it was potentially activating part of the immune system. And what they were seeing was some irritation actually in the liver. So some patients then stopped the hormone replacement therapy because of that. Some of those women actually carried on for between 6 to 12 months because they were, I'm assuming, enjoying the benefit and the reduction in some of those acute symptoms. Yeah. The study didn't go into much more detail about the underlying mechanism because I don't think they fully understood at that point what was happening and the impact that the estrogen was having. Yeah. We do know, though, that it also matters the donor kidney, the person that that's come from, the age of that person, and whether the donor was a male, female, or premenopausal or postmenopausal. Because actually, if the kidney has come from somebody who has been, and don't quote me on this exactly because I've forgotten which way around it is, but if it's come from, say, for example, a postmenopausal woman into a premenopausal woman, there was less of an issue because of changes in the kidney from the donor. Okay. So my knowledge on this is very much from reading some research about it, but I'm currently speaking to the kidney specialist at Salford Royal to see if we can work out what the safe options would be for transplant patients. Okay,
I guess perhaps we would have to bring you back, especially just specifically for kidney and transplant patients, because quite a few of us are worried about taking HRT and how it would actually react against our our anti-rejection tablets. So I'll just move on quickly to the next one. Someone's just asked, Chikodis just asked, if she can have her womb removed electively, perhaps to combat the signs of menopause?
That's a really, really good question, which some women then realise, hang on a minute, if this is a lower reduction potentially by having a hysterectomy, can I not just electively opt for that? I don't think you can. I'm not aware of that being considered. And I've done a few searches to see if that has happened. I've not been able to find that, so I think it's based on known indications for a hysterectomy, and I don't think to reduce potentially future breast cancer risk if you want to go on HRT is in that list, unfortunately. But it's a really good question.
Okay, so I think the next one is from Georgia, and she says, "Can collagen be used also like HRT?"
Not that I'm aware of. So my understanding with collagen is that collagen is a protein which has structural benefits in different tissues, but actually collagen supplements, when you essentially take collagen supplements, they're broken down in the body just in the same way the proteins are broken down. So they're broken down into their building blocks, amino acids, and then the body absorbs those amino acids. I'm not aware of collagen having benefits for those symptoms, but I could be wrong.
Okay. So I've moved on to the question and answer section because I had both. I had a lot of questions in the chat, but so I've moved on to the question and answers. So Estes Stewart says fibroids are said to feed on estrogen. Can progesterone or only HRT be given?
So I would then say at that point, when we're thinking about hormone replacement therapy in the context of other gynecological conditions, at that point I also speak to a gynecologist or a menopause expert that works in potentially secondary care, because I'm in primary care, and then discuss other options. So I know that one option would potentially be a Mirena coil, where that would, so the Mirena coil is not just for contraception, it's also licensed in the UK to give women the progesterone component of their hormone replacement therapy. So one option would be, depending on the severity of the fibroids, and a discussion with a gynecologist would be, can we try estrogen with a Mirena coil so that the progesterone in the Mirena coil is acting locally in the womb and potentially helping those fibroids. But obviously, some women with fibroids are quite sensitive to any changes in hormones. So I would then base that decision based on their pattern of symptoms before this point, what they have tried, what has worked and what hasn't, and also the size of those fibroids and any associated bleeding, and whether we've actually ruled out any other causes of that bleeding as well.
Okay, wonderful. So I've got Sarah Jane here, and Sarah said, "I've had a pancreas kidney transplant, and my GP has just prescribed HRT patches. But after only a few days, my upper abdomen bloated that severely. I couldn't breathe, and it was really uncomfortable. Is this normal because I've temporarily stopped it?"
So hi, Sarah. I think we've met before, so nice to see you again. And I think this question is quite a specific clinical one. So my rider to start off with would be, don't take what I'm about to say as your clinical advice, because I don't know your full clinical history.
Yeah.
From what you've said, though...
Sorry, can I just quickly interrupt you there? Sorry, Stuart. She's written extra two comments. She says she's 10 years post-menopause and 5 years post-transplant, CKD diagnosed 2013, and she's diabetic nephropathy caused her CKD. So those are the comments she's made.
So thank you for the other information as well, Sarah. So in terms of me kind of pulling all of that together, my first thing I would say is that we know actually that chronic kidney disease can cause problems with periods. The frequency of periods can essentially cause a temporary cessation of periods. It can bring on early menopause or symptoms of the menopause earlier than otherwise would have happened. And actually, some patients, after they've had a kidney transplant, then report periods normalizing again. And that's because of the impact that kidney disease in the later stages can have on the rest of the body and the brain and periods. So in my mind, I always then think I correlate what you have gone through with your actual age as well. And then with regards to the symptoms that you've mentioned with patches and combined patches, some of the side effects that I mentioned to women that are common after starting hormone replacement therapy are bleeding, bloating, and breast tenderness. And they are very, very common. And I usually say that obviously, if there's any symptoms you're concerned about, come and speak to me. But as we add in hormones back into the body, or we change doses or switch to different types of hormones, whether that's the gel to the patch to the spray to the tablet, that I say the same again, that we may experience bleeding, bloating, breast tenderness. They're the most common ones. So bloating is quite common, but from the way that you've described it, where it was that severe that you couldn't breathe, I would then want to see you very quickly to understand more about what you're experiencing. So that would be my best answer. And I think given what you've written and you've stopped the medication, I think it's definitely a reason to speak to your GP.
Thank you very much, Stuart. And I think the next question is from Fumi Trave. And she said she's had hysterectomy done last year, but she's not on any medication. Does she need medication? So,
so this question is, I often get this question when, if I'm, for example, out with friends and we're talking about hormone replacement therapy, and somebody overhears and somebody said, "Oh, can I ask you a question?" And it all depends on what you need, Fumi, and what is right for you and your symptoms and your overall health, and your family history and any of those risk factors that you have for future diseases. So I can't say whether you need medication. What I would say, though, is that you've had a hysterectomy. I don't know the reason for that. But I would say it's definitely an opportunity for you to then have a discussion with your healthcare provider to say, actually, I've had a hysterectomy. I've used the Balance Menopause app, and I've assessed my symptoms of perimenopause, or now essentially menopause, because you will have gone through what we call a surgical menopause after having a hysterectomy. And what are my options? What is your best advice? So I would say pick that up with your GP or your practitioner that looks after you, because we know that actually a surgical menopause can often lead to a rapid onset of menopausal symptoms, even if they've left the ovaries inside.
Okay, so the next question is from Georgia, and she says, can we get HRT OTC, or is it strictly prescription based?
So it is prescription based, and naturally, because of associated risks and the side effects that you can get from it, it needs to be prescribed. You need to go through that consultation. Usually a consultation for me for a woman that I've never met before and hasn't had HRT usually takes me a good half an hour to be able to go through all the questions and understand the full context for the woman. So for that reason, it is prescription based, and you would need to speak to a doctor.
Okay, so wonderful. I think we've got quite a few questions we came through by WhatsApp. So yes, well, I don't know if we'll be able to finish it today, but I'll just ask you one, which usually it's something that comes up all the time, and it's mostly people who don't like taking medication and they consider natural remedies instead. So someone's asked about natural remedies, and they've asked if you recommend turmeric as an alternative to HRT to combat the symptoms, to balance the estrogen, moringa leaves for inflammation, pickles, kimchi, sauerkraut, and a few other things. So they're asking if that could be alternatives they can use instead of using HRT.
So the evidence that we have is that hormone replacement therapy is the most effective treatment for the symptoms of perimenopause and menopause. I know there is evidence for the anti-inflammatory nature of certain foods, and if that was the only reason that somebody was experiencing symptoms, you could potentially argue that yes, that food-based solutions or complementary therapies that had a proven record to be anti-inflammatory would be helpful. However, the symptoms that a woman experiences during perimenopause and menopause are in relation to changes in hormone levels. And I'm not aware of those ingredients being able to stimulate the androgen receptors in ways that then increase the existing production of hormones, or that those ingredients have the same structure as hormones. But equally, I'm not an expert in
Natural.
so either food-based medicines or naturopathy. So in terms of what I can recommend as a UK GP, it's based on the NICE guidelines and a whole host of medicines which are authorised by our commissioners. But just even from reading on this subject, I know there are plants which have phytoestrogens, so soy-based products, for example. However, the amounts that you would have to consume potentially to get the same that you would do in our medications is so high. The other issue with some herbal remedies as well is that in lots of countries, the regulation around herbal supplements isn't there. And there's been quite a few studies which have shown the variation even within one tablet in the same pack with another tablet in that pack, where one tablet has got, for example, 400% more of the active ingredient compared to another tablet. So that variability, I don't think is good enough. You can't rely on that to manage these difficult symptoms because you don't know the concentration of what's in those tablets.
Okay, wonderful. Thank you very much. I hope she's listening, or she's listening to this replay, and she can take that information she's just received away with her, because a lot of people would prefer not to take more medication and look at natural alternatives instead. The next question is a funny one, but someone's asked if men do go through menopause.
Yeah, so I call it the manopause. Its real name is the andropause, and it's something similar. Not as probably as severe as the perimenopause and menopause, but we do know that several other conditions cause this testosterone deficiency or this loss of testosterone in men. So in the UK, it's in our diabetes guidelines to screen patients with diabetes for testosterone deficiency. And testosterone is incredibly important for bone health, muscle health, for brain health, for what we call metabolic syndrome. So diabetes can be essentially it's a metabolic condition where the body's struggling to process certain energy sources, which then result in the condition of diabetes. Well, I'm specifically referring to type 2 diabetes, not type 1 diabetes, for example. So we know from research that was done during the pandemic, and I think it was in Denmark, that many of the men who had severe COVID infections and were on intensive care, the men that unfortunately passed away all had severe testosterone deficiency. Now, obviously, we can't say that severe testosterone deficiency was what caused them to become so unwell, but there is a correlation that actually many conditions that people have, that very, very common conditions like obesity, type 2 diabetes, cardiovascular disease, they have consequences for testosterone production in men and women. And I think in addition to us trying to raise awareness for women's health, actually we should be trying to break down the taboo of sex hormones for everyone, because actually sex hormones are very, very important parts of our physiology, and I recommend lots of men to get tested for testosterone as well, because it's very easily diagnosed and very important.
So what age do men go into menopause?
So it depends on their existing conditions, but it can happen from 35, 40, 50, 60. It really depends on their overall health as well, and their activity levels, their diet, their family history.
Yeah.
It's very variable, just like it is for menopause.
Okay, wonderful. Okay, so the next question is why do transplant patients go into menopause earlier than they should?
So my understanding of this is because of the stress on the body
Okay.
with chronic kidney disease
Yeah.
and the impact of the kidney disease on different parts of the body. So
Yeah.
we know that with the urea and creatinine raise,
Yeah.
that can have impacts on different parts of the body, and those are some of the byproducts that normally the kidneys would be able to get rid of.
Yeah.
So as they increase and some of those toxins that the kidneys would be able to get rid of increases,
Yeah.
and we know that the acidity of a patient's blood starts to change a little bit as well as kidney disease develops, that has an impact then on the different stress responses in the body. So we know, for example, that night shift workers or women on night shifts, sometimes they experience disruptions to their menstruation because actually the stress of the night shift temporarily disrupts that normal pattern between the brain and the ovaries. So I think it's a similar mechanism.
I see. Okay. Thank you for that. And I guess a lot of people are learning from this today, especially those watching the replay. Now, I think I will make this my last question because I've got 2 pages of questions, which I'm going to pass on to you and, send to you by email so that you can answer them. And I will put them on our social media as well as do a video with all the questions so that people can actually look at them and perhaps if you can just do some like a little video answering the questions, that would be wonderful. So the last question is that many women over the age of 68 are told to go off HRT. Is this right? Is this right advice, or should women over 68 stop HRT? So I think this is age related.
Yeah, this is a really good question. I get this question in clinic all the time. What I usually say is that advice, which has been around for a long time, that you should only be on HRT for a set period of time. The British Menopause Society have now done away with that advice and say actually there's no arbitrary time limit on hormone replacement therapy.
Yeah.
It's based on a woman's individual needs. And the assessment of her own situation and her own symptoms and the balance between risks and benefits.
Yeah.
And all that HRT is, it's a treatment for some symptoms, and it has some benefits and it has some risks, and they differ from person to person. And that's the way that I explain it to my patients, that let's consider it just as we would do for any treatment.
Yeah.
What are we giving it for? What are the risks? What are the benefits? And actually, what does the woman want? Are you happy to accept those risks because you place a greater value on those benefits? And we make that decision together. I present the information in ways that are understandable to you, and then we come to what we call a shared decision using the best evidence. And if you want to go ahead then and stay on that treatment, I say, okay.
Okay, wonderful. Thank you so much. Now, just to round up, you've talked a lot. I cannot even summarize everything you said today, and I'm sure that everybody who is listening has actually gotten a lot from this session. I didn't know how much information you just so knowledgeable about everything, and coming out and talking, giving your time to us as a community, talking to us about menopause and HRT, which is an issue within the Black community, especially with kidney and transplant patients. I want to say thank you for taking the time today to come and speak to us. So do you have any last words, any last advice for people? And if there's anything you're involved in the future?
Yeah, so there's 2 things that I would say. So, well, no, 3. So first thing, Hilary, thank you so much for inviting me. You know from our conversations before that I'm happy to talk about menopause, hormone health, women's health inequalities all the time. So thank you for welcoming me. The second thing I was going to say was I've just seen one of the questions that I can't not answer because this is a real frustration for me, and it's from Lucy Jacobs. which was when a man in his 50s has low testosterone, but the levels sit on the lower figure of the acceptable range, the NHS won't prescribe anything. You have articulated one of my biggest frustrations. One of the problems with doing hormone testing is that we haven't traditionally done it for a long time we haven't done it for menopause and testosterone deficiency for many years in comparison to the level of hormone tests that we do for other conditions like thyroid, for example. I think doctors are very comfortable with interpreting the results for other blood tests, but when it comes down to something like estrogen levels, progesterone levels, testosterone levels, sometimes you can fall into a habit of just looking what's in the range that we give you. And the problem is that the range for testosterone is a very wide range. And the most important thing is to correlate that blood test result with the symptoms, because we don't treat blood tests, we treat patients. Okay. Actually, if a patient has symptoms of testosterone deficiency and they have a blood test that is in a certain range, I always say, if you're not getting the answer from the first person, potentially ask for a second opinion, or ask for a referral to an endocrine specialist, somebody that might have more experience and competence with managing endocrine problems or hormone-related problems, because they're very, very they can be quite complex, even though they are common, and the amount of training that GPs get on hormone health specifically is limited. So the issue with testosterone, for example, is that they don't give you an age-adjusted range, because the testosterone result for an 18-year-old patient would be very, very different for a 70-year-old patient. Yeah. They can both end up in the normal range and be classified as normal, even though actually if we adjusted for their age, you might think actually this is an abnormal result. So that was my last point with regards to the questions. And then the final thing that I wanted to mention, Hilary, was that obviously, you know, from our discussions, I'm very, very keen on sharing this information with a variety of communities and people that traditionally don't get access to this information. Yeah. We know that the vast majority of patients that have hormone replacement therapy are white women for menopause hormone therapy. And actually, we have talked about just transcending these traditional boundaries, because this is women's health. This is the health of people in our communities. Yeah. And they should have access to this information, because this information it transforms lives. Yeah. We know that suicide peaks during the menopause as well. So this advice can literally save lives. So what I obviously will be working on with you, Hilary, will be sharing more of this menopause advice with different underserved groups from within the Black community, minority ethnic communities, areas in more deprived areas across Greater Manchester. So that's what we have in the pipeline. We want to kind of take this further. I'm looking forward to it.
Oh, wonderful, wonderful. I'm really glad that, you know, you were able to make the session today. Everybody, I hope you've had a wonderful time. I'm actually looking at some of the comments in the the chats, and Rihanna says, thank you. This has been very informative. Absolutely brilliant. Ayesha says, thank you so much. Awesome session. She's downloaded the app as well. Really nice. ST Stewart says, so enlightening. Thank you both. And Louise Priya says, thank you. Rihanna says, I'm Asian Pakistani heritage, so thank you very much. So thank you again, Stewart. I'm hoping that once the workshop starts, that we'll be able to reach out to people in the Black community, in the Asian community, across Greater Manchester and across the world, because people from Nigeria have actually signed in today. I've had so many from my home country actually signing in to listen to you today. So I hope that these sessions that we're going to be having is not just going to be only, geared towards women in the UK. I'm going to try as much as possible to make it hybrid so that people from Africa can join in, because it is a session, I think, informative, that I think people, especially women who don't have that access to this kind of resource can actually learn from and help themselves as well. So it will be women from Africa, from America, Canada, Asia, as much as I can get them on, because believe me, this is really important. That if we have somebody who's willing to show people how to, women especially, how to look after their health, their sexual health as well, then why not? We can do that. So thank you very much. And everybody, thank you very much for coming out today. I just want to talk to you a little bit about another project that's WSH-BME Kidney Network, which is our charity, is working on with Kidney Research UK. As you all can see, I'm wearing the Kidney Research UK t-shirt. I'm a peer educator with them, and this is what I do as a peer educator with them, as well as with my charity. We're working currently on a project called Antennae, which is looking at research, because we as a Black community, we do not get involved in research. So we're trying to work with people from the ethnic communities, so Asian, Black, every other person from, every other ethnic group in the UK, well, based, primarily from Salford, Oldham, and Rochdale. So if you live in these areas and you think you would want to get involved in this project, please contact me on wsnhuk@gmail.com, and I will put you in touch with Nija Jane, who is the quality manager with Kidney Research UK. It's going to be actually a project that I think that we as a community have to get involved in, because it would be beneficial for us, because we are the ones that have the health issues which most people do not understand. And with research, working with Kidney Research UK, they can actually throw a lot of light on those conditions, especially for kidney patients, which we actually go through, and they can understand and help us more. So that information will go out on our social media platforms very soon. But once again, I just want to thank Stewart for coming out today to speak to us about menopause and HRT. It has been really informative. Until next month, June, which is also our charity launch event. We're launching our charity finally, so everybody knows about us. But we're still going to try and see if we can fit one session into that month, because we're really passionate about all of you, kidney patients and transplant patients and your families, the issues that affect you every day in the UK. So thank you once again for coming on. And Stewart, I'm looking forward to working with you soon on those workshops. I'm really, really looking forward to them. So thank you, everybody, and have a wonderful weekend. So from me, over here in sunny Canton in Massachusetts, USA, thank you very much, and bye.
Thank you, Hilary. Bye-bye. Bye, everyone.
Bye.
Bye.